Hey guys, so one of the most common questions I get is in relation to medical necessity. Is the care a covered service? How do we differentiate cash-based services versus covered services? And so I'm going to share my screen in a minute. I'm going to show you a Medicare LCD. I'll link to it down in the description of the video. But take this one, and I know you can't just take a blurb out of context, but let's discuss this for a second. So let me share my screen. Okay, behind me, you can see this little bullet point right here. So it says, quote, if a patient's limited ability to comprehend instructions, follow directions, or remember skills that are necessary to achieve an increase in function is so severe as to make functional improvements very unlikely, rehabilitative therapy is not required and therefore is not covered. However, limited services in the circumstances may be covered with supportive documentation if the skills of a therapist are required to establish and teach a caregiver a safety or maintenance program. So let's talk about that specific little block right there. Let's take a classic example, right? I'm treating a patient has multiple comorbidities, complexities, patient has Parkinson's, patient has some orthopedic issues like low back pain, right knee pain, left shoulder pain. The patient has been having repetitive falls while living at home with his spouse. The patient does not drive. The spouse is bringing the patient to therapy. The patient does well. The patient benefits from coming to therapy. There's no doubt about it. There's better mood, better affect, better, cognition. Obviously, the patient feels better. But the thing is, those improvements, those gains, are they lasting? Will they persist? Once I've determined as the therapist, I've done the initial evaluation, I've developed the plan of care, I've established the goals, the function-based goals, I've done the educational component. Now, there's language in the Medicare LCD that clearly states simply because the patient doesn't have access to an aide or caregiver or family member that can help with the prescribed home program does not mean that when the program is done by you, the therapist, it becomes a covered service. It's still not a covered service, which means that it should be paid for out of pocket. But that being said, the whole idea here is once I, as the clinician, have checked those boxes and done all of that, there comes a time where I have to say, okay, we've got two options here. Either I've determined this person absolutely can learn, understand, retain the information. I've shown them what to do. I like to simplify things down to 2 or 3 things. So I've shown them the 2 or 3 things that are going to give them the most value, moving them toward their goals over the next couple weeks or months. At that point, my job is done. Now, I don't have to officially discharge that patient. I can transition them to a maintenance program where they're getting occasional intermittent follow-ups with me to assess progress and update goals and change the plan of care, but they're not getting ongoing 2 and 3 times a week treatment with me as a billable service. They can self-pay for that, but that component of the treatment plan is finished. Now we're making the transition to combination of covered and potentially non-covered maintenance services, or I make the determination that unfortunately this patient doesn't have the cognitive skills, doesn't have the ability to learn and retain and really utilize the information that I'm sharing, and they don't have a support staff, a support system around them. They don't have aides, they don't have family members, they don't have a spouse that can help or is willing to help with what needs to be done. In either of those cases, the rehabilitative portion of the plan of care is complete. I can still continue to offer occasional follow-ups under a maintenance program, but I cannot continue to provide one-on-one covered services under Medicare 2 and 3 times a week, simply because if the patient stops coming to my clinic or you as a mobile therapist stop going to the patient's home, the patient declines. Maintenance is not continued therapy when covered by Medicare once you've established those 2 criteria. So either the patient's going to be able to do it and do it, or the patient's not going to be able to do it. In both of those cases, you've made a determination that rehabilitative therapy is complete. We move to a maintenance program, but then you have to determine, well, what's a reasonable frequency for maintenance? I do not believe twice a week, just like rehabilitative therapy, is reasonable for a maintenance program. I think once every 6 weeks, once every 9 weeks, 12 weeks, you check in, you update programming, you see how they're progressing. Maybe they decline. Maybe at some point it does justify returning to a rehabilitative program where you increase the frequency. This is totally, I believe within the realm of reasonable and medically necessary. It's important that we remember it's a two-part saying. It's reasonable and medically necessary. Do I expect reasonable improvement, slowing the decline, all of those things, in addition to, is it medically necessary? And you can't make that decision in a vacuum, right? You have to look at all the factors. You have to look at everything that's going on. So whether we're talking about, highly complex neurological conditions, whether we're talking about orthopedic conditions, we know that patients do so much better when they're working one-on-one with you. It's an amazing opportunity, but it's not something that Medicare should be covering for 52 sessions in a, 365-day plan of care. Like, we have to be good stewards of Medicare dollars, and we have to understand that there is always an opportunity for cash-based services as supplemental services to Medicare covered services. So guys, I'm going to do a couple more little videos like this, teasing out, like the next section I'm going to talk about is how we can integrate sports performance, recreational activities as part of a self-pay program that's in conjunction to a Medicare covered program, but not as a covered service. I'll catch you on the next video.